مش عايز اقول لك خبرته العالمية قد ايه في البوكس وفي الايكو،
أنا شاكر
لدرجة
جدا.
ان هو وجد بوزيشن مهم جدا في انجلترا بسهولة. مم.
أنا يعني very thankful Dr. Hassan for this great invitation actually. And I'm very, very proud to be with you as I used to have before. And actually, my talk tonight will be focusing on something with some important highlights on messages. Uh, and the reason why I choose this title of this presentation, which is why we have to have point of care ultrasonography, which is the integrated echocardiography with the other part of the point of care ultrasound, particularly the lung ultrasonography in managing patients who are acutely ill in critical time. And tonight I'm going to focus on the EF. We receive a lot of patients with EF, and as everyone knows that EF is very common in up to 25% of population in the age above 40. They develop EF for whatever reason. It might be lone EF, maybe heart ischemic heart related EF, hypertensive heart disease, thyrotoxic heart disease, valvulopathy associated EF, and many other things. And in ICU particularly, we have up to 46% of patients in septic shock. They develop EF. And EF in septic patients is considered one of the detrimental factors that it's associated with higher mortality. Not only that, but also 40% of patients in post-cardiac surgery, they develop EF for whatever reason. And that's why if you look at the guidelines, and people, they forget this message. Every guidelines, the European, the American, the ASICM, ICU, Society of Intensive Care, the European Society, everywhere you're going to see among their recommendations that echocardiography, seeing the heart, is considered to be one of the class A recommendations, that you have to treat this patient not only to decide to control the rate or to control the rhythm, but before you go with whatever plan you want to go with, you have to see the heart. Echo is considered mandatory in every patient who develop either new onset EF or acute and chronic EF or chronic EF. They have to have echo examination. And what hurting is that people, they believe in that. They believe that every patient with EF has to have an echo. But where is it in the prioritization of management plan? Yes, we will request EF, but echo. But where to do this echo? It doesn't great matter. So it might be done today, tomorrow, after a week, as outpatient, while the recommendations are very clear and logic is very mandating that to see the heart immediately is very important in putting the management plan, because echocardiography doesn't tell you numbers, does not allow you to hear about the heart, but to see the heart, to see not only the anatomy, but the function. And by seeing the anatomy and understanding the physiology and function, you put risk stratification, and then on ground, which is very solid, you're going to guide the management of this patient properly, I believe. One of the very important questions that we receive every day in mind when we see patients with EF, some of the patients, if not the majority, they might come not because of feeling palpitation, but they feel things other than palpitations. So they are not aware if they have AF before or not. They might tell you, I'm not feeling palpitation. I don't feel my heart racing. I don't feel that my heart is irregular, no, but I feel short of breath or I have chest pain. And then the dilemma of having this patient who, for example, present with EF with very high rate, you ask yourself and you may decide if the patient gives you confusing history that I may give a rhythm control and cardiovert to this type of patients. While if you look at the heart, you might see clues or signs that tells you that this heart is not with acute EF, but it's a chronic EF. One of the landmark of chronicity of the EF on echo, once you put the probe on the apical 4, like what you see here, or in the parasternal lung, and you look at the left atrium, when you see the left atrium dilation, and this is just by eyeballing, as we are simplifying the echocardiography, and it is simple to have, once you have the image, to have simple interpretation using your eyeballing. As one of the rules in bedside echocardiography in general, that the three structures of the RVOT and aorta, valve and base of the aorta and the left atrium, they should be each one fulfill the third of the screen here. And roughly the LA, the left atrium, should be at the same size or slightly less, might be slightly less, might be equal to the RVOT. So if you see the left atrium as you see it here, bigger than the RVOT, then this left atrium is dilated. You can see here also in the apical 4 chamber, just roughly by eyeballing, this is the left atrium. The borders of the left atrium, as we all know, they start from the mitral valve here down to the end of the atrium when you see the pulmonary veins coming into the left atrium here at the base. So roughly the left atrium in apical 4 should be again smaller than the size of LV, and sometimes it's less than 0.6 or 0.5 the LV normally. When I see in somebody like this patient, the left atrium is equal to the left ventricle, might be bigger than the left ventricle. So this left atrium is not at all small, it's dilated. Dilated left atrium with EF is considered to be because of a chronic EF. Differential diagnosis that has to be in mind, which is very important, as we know, that dilated left atrium can be due to mitral stenosis as well, left ventricle long-standing diastolic dysfunction, and left ventricle systolic dysfunction. But come back to the question, am I dealing with acute or chronic EF? If I see left atrium is dilated, particularly if I don't have signs of mitral stenosis, then term of acute EF here has not to be in the list. This patient has a chronic EF. And the bigger the left atrium is, the higher the risk of thrombosis formation in the left atrial appendage and in the left atrium in general. So I wouldn't at least consider to rhythm control this patient or to revert them to sinus, except if I have a strong evidence that this patient left atrium is not containing any thrombi, and cannot be solved without transesophageal echo. So echo here, don't agree with me that it's mandated in a patient like this just to have a lock on the left atrium. And how much time it takes to have a probe bedside, and you just go and put it to the parasternal lung and or the apical 4 and have a lock on the left atrium. And at the same time, you can see the function of the left ventricle. You can see the opening and closure of the mitral valve, and a lot of information can be taken from the simple examination. As we know, as I said, left atrial dilation is considered to be an independent risk for uncontrolled AF, and it is a consequence of the EF. And if it's there, it will make your patient most likely unresponsive to the rhythm control or even the rate control. Very important to know that. And that's why the guidelines, the recent and old guidelines of managing EF in acute care settings, in ICU or outside the ICU, sometimes it's mandated to have an evidence, not sometimes, but it has to be done, evidence to classify patients with left atrium dilation and impaired function or not. If the left atrium is not dilated and the ejection of the left atrium, the function, the systolic function of the left atrium, which is known as left atrial ejection fraction, we can measure this, but this is a little bit sophisticated. Then, if it's still there, the left atrium normal, you can go with the rhythm control. If it's dilated or the ejection percentage of the left atrium is less than 20%, then it's dangerous to go with rhythm control and rather to go with a rate control. It's one of the very important points that the echo will tell you about any patient with ejection fraction, with AF, that if you have EF with preserved ejection fraction or EF with a reduced ejection fraction. And this is very crucial because because of EF, the heart failure might develop mild or moderate heart failure once you have EF in up to 15% mild to moderate heart failure. The heart will fail if the rhythm is not controlled, if the rhythm is disturbed in EF. And it might go to severe heart failure. But not only that, the percentage is also that in mild to moderate heart failure, you have up to 15% of patients with mild and moderate heart failure, they develop EF. And those with severe heart failure, almost 50% of patients with severe heart failure, systolic, reduced less than 30% ejection fraction, they develop EF at one or more times of their life. Very high percentage. Not only in the left ventricle, but also in the right ventricle. Whatever the etiology of RV dysfunction, 30% of patients with RV dysfunction, they develop EF. And always, the RV is forgotten in every things in critically ill and non-critically ill patients. We always look at the left ventricle, blame the left ventricle, treat the left ventricle, and we ignore or forget the right ventricle. Right ventricle is so critical, so dangerous, so beneficial, so everything like the AF, the left ventricle. It's equal to the left ventricle in importance. And you have to know that in any RV dysfunction, whatever the etiology, hypoxia-induced RV dilation or dysfunction, pulmonary embolism induced RV dysfunction, acidosis-induced hyperventilation, hypercapnia, permissive hypercapnia induced RV dysfunction, in ERDS management and using the recruitment maneuver or high PEEP induce RV dysfunction, all of this type of patients, they might be precipitating the occurrence of EF, and this is by evidence. This is very important to put in mind. Very important to put in mind that the left ventricle diastolic dysfunction, which can be picked up by the echo, and there is no other way to diagnose left ventricle diastolic dysfunction rather than echo. You might go with a Swan-Ganz to see pulmonary capillary wedge pressure, or to go with the thermodilution technology to have this and that. But the echo will tell you with numbers and with eyeballing if your patient's heart is suffering from the left ventricle diastolic dysfunction, which grade is 2 or grade 3. And why this is important? Because as more as you go and deteriorate the left ventricle dysfunction, as more as it goes from degree 1 to 2 up to 3, when you go to 3, there will be no benefit at all from rhythm control. If you have evidence of left ventricle diastolic dysfunction, stage or grade 3, then rate control has to be the prioritized management plan over the rhythm control. Also, as I mentioned just now, that you have to know before you decide to go with beta blocker if your patient is going to be beta blocker responsive or unresponsive. So this might be a little bit new term. We hear of fluid responsiveness and fluid unresponsiveness and so on. But we don't hear much about the beta blocker responsiveness. Do you think that every patient with EF will be responsive to beta blocker? Unfortunately, most of the treating physicians in acute care settings, they believe on that once they have EF, they throw immediately the beta blocker, give bisoprolol with this dose or that dose. They might give it IV, oral, they might go with metoprolol, they might go with this or that. But before you decide to go with a negative inotropic drugs to the heart, you have to have an eyeballing assessment of the biventricular function to know if this heart will tolerate the negative inotropic effective drugs or not. And share with me your opinion here. If you have this patient with EF who came to the emergency room with a heart rate of 140 per minute, though the blood pressure is maintained, and the treating physician went and decided to give up to 12.5 milligram, 2.5 after the other, till they reached more than 12.5 milligram with no response. Rather, the heart rate was deteriorating with beta blocker. And as simple as that. If you look by the eyeballing, again, simplifying things, have a look on the heart, on the apical four chamber, or whatever view you want to have, a look on the left ventricle and right ventricle, and see, is this heart is racing and hyperdynamic, or it's racing and hypokinetic, and what degree of hypokinesia you are dealing with. Is it mild? Maybe tolerates the beta blocker. Is it moderate? Plus minus. If it's a severe LV systolic dysfunction, the heart would fail more if you give beta blocker. And without echo, how would you know if the heart is beating just a flickering of movement? The heart is not effectively beating. So the cardiac output here is not at the stroke volume, is not at all maintained. And if you just remember the physiology to know that the cardiac output is a heart rate times the stroke volume, you would know that this patient's heart blood pressure is maintained because the heart rate is compensating for very low cardiac output, for very low stroke volume. Not only that, but also the systemic vascular resistance is very high. The cardiac output is the stroke volume times heart rate. The blood pressure is cardiac output times the resistance. So the resistance is very high and the cardiac output is very low, but the heart rate is very high. So it's compensating. But then at the end of the day, this patient is not, the heart is not functioning well. And if you're going to go and look at the heart rate and to try to control it with beta blocker, this heart will fail more. And what you need here is two things: to treat the reason for this heart rate, to be very quick like this. Either it's a heart failure because of heart failure. So the main cornerstone management plan here has to focus on anti-failure medications and you try to reduce the resistance, the systemic vascular resistance as much as you can, and you should avoid totally at this moment beta blocker, especially if you look at the lung and you see how wet is the lung here. Look at this loop of lung ultrasonography. You would not miss at all that this patient's pleura is attached to it, a very severe, several vertical lines, we call them B lines, indicating a very congested interstitium and a very wet interstitium due to pulmonary edema. And again, the diagnosis here is very important, that in this loop of guidelines, what I'm dealing with is a left ventricle function with very reduced ejection fraction, that you have to go not with the beta blocker, but see here, the rate control. If you go with the rate control, you go with amiodarone, digoxin, or if you are dealing with unstable AF, then you go, if there is no high risk of embolization, you go with DC shock. One of the very important points that we face in EF and some other type of patients in acute illness, that the development of acute cor pulmonale. We know that when the pulmonary circulation resistance increases and the pulmonary pressure increases, patients develop what we call it pulmonary capillary dysfunction, PCD. And the PCD are different. Again, there are mild, moderate, and severe pulmonary capillary dysfunction. Again, the development of in EF of RV dysfunction and even pulmonary capillary syndrome is considered to be not uncommon. When you have pulmonary hypertension, systolic pulmonary artery pressure more than 40 millimeter of mercury, and RV dilation only, then you have mild or moderate pulmonary capillary dysfunction. When you have only dilation of RV and the size of the RV goes beyond 0.6 of LV, and you try to measure the pulmonary artery pressure, you find it more than 40 millimeter of mercury, you are dealing with mild or moderate. Once you see the interventricular septum is dyskinetic, i.e., it moves from paradoxically toward the left side in the parasternal short axis view, or even in the apical four chamber view. When you see the septum with every systole moves toward the left ventricle, this is a significant sign to determine if the patient develops severe PCD or not, pulmonary capillary dysfunction, which we know it as acute cor pulmonale. Why this is important? Because in every, if we just remind each other with the statements that we know it from the school of medicine years, that the most common reason for the RV to dilate and fail is the left ventricle failure. This is very, very well known. But not every RV dilation is a failure. And not RV dilation and pulmonary hypertension is acute cor pulmonale. EF patients, those with chronic EF, they have left ventricle diastolic dysfunction because of EF, just only because of EF. They might have other systolic dysfunction because of heart failure. They might have long-standing mitral stenosis, but AF per se, without any other cause, leads to development of left ventricle diastolic dysfunction. And long-standing left ventricle diastolic dysfunction will result definitely and eventually into right ventricle dysfunction. So I would expect in every patient with EF to may develop RV dysfunction and dilation. But what makes me, or anyone who used to use the echo, in every patient who present to ER or ED or to ICU with acute EF or acute on top of chronic EF, to put in mind that I have to assess this RV as I did assess the LA and LV. This is not less important than the left ventricle. When I look at the right ventricle on this patient, I discover that the RV here is dilated, can be expected. And if you look at the left atrium, you see how hugely dilated it is, but also the RA is also dilated. And if you focus on the RA, I hope it's clear far away when I present from my computer to you or I, that you can see that there is inside the right atrium a mass which could be a thrombus. And this patient is not known to have any pathology on the RV before, at least as far as we know from the file and the system that the patient has. When we looked at the IVC, as you see here, and we zoomed on the IVC, this is the IVC, it's opening into the right atrium, you can see that there is a hyperechoic, gray-looking mass that inside the IVC looks like a thrombus. When we focused and zoomed on the IVC, we can see that the IVC contains a thrombus. So this patient's uncontrolled EF that he presented with is probably because of new development of acute or acute on top of chronic pulmonary hypertension. Here, it would be called acute cor pulmonale. And what raised the suspicion of being acute, not chronic, is that the jet velocity on the tricuspid valve, the velocity was not higher than or equal, around equal to 2 meters only. So the pressure difference across the tricuspid valve was around 20. So the systolic pulmonary artery pressure, when we repeated the measurement, because it's EF, you have to have many measured tricuspid jet. Then the average, when we measured the average of the tricuspid jet pulmonary artery, systolic pulmonary artery pressure measurement, as we know by the equation that we use, the velocity times 2 is times 4, and then this the pressure across the tricuspid valve. You add to Bernoulli equation. You add to this the central venous pressure, which you can estimate it from the size of the IVC and collapsibility of IVC. Then you know probably how much systolic pulmonary artery pressure is there with this RV dilation. Then you pick up if the pulmonary artery pressure is less than 60, that this is likely to be acute. So our mind now to diagnose why this patient is presenting today with acute on chronic uncontrolled or fast EF is probably because of pulmonary embolism. And what can increase the suspicion of pulmonary embolism here is that despite the low systolic ejection fraction and low function or impaired function of the left ventricle here, you would expect the left atrial filling pressure to be high, and you would expect that the lung to be congested. But what you see here on the lung ultrasound exam, that the lung is rather oligemic or hypooligemic, so it's not congested at all. See here, this is the pleural line, and you don't see at all any B lines here. And here at the base, on the basis of the lung, you don't see at all any B lines, maybe 1 or 2. So the lung is not congested, though it's a chronic EF, though the left atrium is hugely dilated. So with this integrated critical care examination of this EF patients, the management plan was directed toward a very different pathway, which is this patient developed EF, uncontrolled EF because of pulmonary embolism. And the CT confirmed that. Valvulopathy, ladies and gentlemen, is considered to be one of the common causes of EF. 30% of patients who develop EF, they have one or more valve pathology. And unfortunately, with valvulopathy and EF, the mortality is higher. And this is very important message here, that the new onset EF, which we face every now and then, new onset EF, when you see them with valvulopathy, this is an indicator to refer them as soon as possible for valve replacement or repair. This is very important. And your patient might not tolerate a month to wait for echo to be done, or weeks for the echo to be done, or even not to be done at all, because we see this. And actually, presence of valve pathology or disease and left atrial dilation, as we mentioned before, once you see, as you see here, that the mitral valve is barely opening, very narrow opening of the mitral valve, and you can see how calcified is the mitral valve, and you see left atrial dilation. This is, by default, is a chronicity sign. So we diagnosed here that this patient's EF is because of mitral valve stenosis, and this is for a long time now, because both of them, EF and the stenosis, induces LA dilation. But what is very important to know is for every 1 ml per square meter increase in left atrial size increases the risk of recurrence of EF by 21%. So this is another important point to know, that even if you control this EF, the recurrence of fast EF or alternating paroxysmal EF will be here by good percentage because of the dilation and because of the presence of the stenosis. So again and again, the echocardiographic assessment of any patient with EF should be considered mandated, because you can see intracardiac thrombi, you can diagnose and know left atrial dilation with its consequences on the risk stratification, on the management plan. You can stratify and diagnose the degree of left ventricle and the type of left ventricle dysfunction, systolic or diastolic, but not only that, but also absence or presence of MR. Why is that? Because MR is a good for EF, because it reduces the risk of turbulence. The turbulence of the blood in the left atrium will reduce the risk of thrombus formation. One of the common scenarios that we see every now and then in acute care settings is that we see patients with uncontrolled EF because of hypoxia. And this hypoxia might be because of, you are confused if this is cardiogenic pulmonary edema or there is element of non-cardiogenic pulmonary edema. And both congestion and hypovolemia with EF leads to uncontrolled EF, leads to occurrence and recurrence of the EF. Hypovolemic patients, dehydrated patients, they develop left ventricle diastolic dysfunction. And if they are hypovolemic and they have already left ventricle diastolic dysfunction before, the diastolic dysfunction will deteriorate. And this will lead to EF, uncontrolled EF, or development of EF. So occurrence and recurrence with both congestion due to heart failure or hypovolemia, even on top of congestion. So you see this patient and you see how ballooning is the left ventricle here, and how ballooning is the left atrium, how bad is the left ventricle systolic function of this patient. By eyeballing, I would say the ejection fraction here is far less than 20%, maybe 10 to 15%, barely. But look at the right ventricle. It's smaller than what I expect. And at the same time, you can see how smashed is the RA with a big shift and bowing of the interatrial septum as well as the interventricular septum, compromising the systolic and diastolic function of the RV. Patient presented with hypoxia, but look at the lung examination of this patient. This is the right base, and we can see here the liver, and this is what we call it the curtain sign. When the pleura come and encroach over the diaphragm and the liver, expanding very well, indicating that there is no pathology in the right base of the lung, right lower loop, to prevent the pleura from reaching the extent of its expansion, indicating that there is no significant consolidation on the right lower loop and there is no significant pleural effusion. Because if you have pleural effusion or consolidation, the pleura will be shifted and the lung will be pushed upward. So if you put the probe at the liver site, at the mid-axillary line, toward the base of the lung, you wouldn't see this expansion clearly as you see. But what we see here is a lot of, we call it extensive vertical lines. We call them extensive or coalescent B line, indicating pulmonary edema. Immediately, we have to look at the pleura to see if the pleura looks normal, shiny, not looking thickened, diseased, corrugated or not. And if you look carefully, you're going to see part of the pleura is shiny, normal, thin, but part of it does not look like at all healthy, corrugated, as you see here, corrugated and thickened, indicating that this patient, when we zoomed on the pleura here, you see how bad, diseased, adhesed, corrugated, dirty looking pleura. This will direct your attention to the presence of not only cardiogenic pulmonary edema, but also a non-cardiogenic pulmonary edema. If you look carefully here at this intercostal space, you see subpleural consolidation, obviously. So this patient not only having pulmonary edema due to bad LV systolic and diastolic dysfunction, but also this patient has underlying lung infection that you have to treat. So sepsis, induced and controlled EF should not be ignored, even if you see a straightforward LV systolic and diastolic dysfunction. Do not ignore to look at the lung to see if there are evidence of infection or not. And you put this as one of the puzzles, plus the CRP or the other inflammatory markers, white cell count, procalcitonin, and etc. But don't tell me that I'm comparing or adding this to chest X-ray, because the chest X-ray is neither sensitive nor specific to any of these pathologies. Ladies and gentlemen, as I said, not only the congestion induces uncontrolled AF, but hypovolemia induces uncontrolled EF. And you have to put in mind all the time that when the patient presents you with EF, evidenced by ECG and bedside monitor, they might revert at any time to a sinus rhythm. And what you have to have, when you look, as you see here, there is no dilation of the left atrium, and the left ventricle doesn't look like with any systolic or diastolic dysfunction, but rather it's very rapidly racing, hyperdynamic left ventricle, as well as the RV is small, collapsing with kissing walls, indicating that when you look at the IVC as well, the IVC is small, and with every inspiration with this spontaneously breathing patient, the IVC collapses significantly, two signs of hypovolemia. And if you look at the lung, because most of patients with EF, they are tachypneic. Again, because the EF, whatever, even if it doesn't look like an echo with systolic or diastolic dysfunction, EF per se induces changes in the left ventricle and right ventricle and might induce a sort of asymptomatic or symptomatic heart failure. So you have to be very vigilant to this. When you look at the lung, you see the pleura very glistening, shiny, and there is no signs of chronicity or disease, the pleura, and there are no B lines at all, indicating that the lung is dry. So what you need to do here is to control the AF by giving first, before you even consider the beta blocker, because this patient is tolerant to beta blocker, but their circulation needs to be filled before you go and give the beta blocker. Otherwise, the response to beta blocker, again, might not be optimum. To conclude and to sum up my presentation tonight, and sorry for being a bit late, that the critical care echocardiography, or some people they like to call it point of care, or some people they might like to call it the famous or focus assessment of AF patients bedside with echo, is considered to be mandatory, and you have to do it, and you have to prioritize it in the management plan, because you have to look at the heart and you manage the heart according to the echo finding. And this is not extreme of a statement, but it's the reality that support and evidence that support that you have to see the heart. Left atrium, left ventricle, right atrium, right ventricle, and the surroundings with IVC all have to be assessed and seen while you are managing your patient. Thank you very much.
شكرا جزيلا دكتور أشرف. وهنفتتح دلوقتي الأسئلة، وأنا أول واحد هسأل لو أنت تسمح لي. هي
My
محاضرة
pleasure.
رائعة طبعا، وواضح فيها خبرتك الجبارة. أنا بس إيه، لفت نظري كذا حاجة. الدايستوليك ديسفانكشن إزاي نشخصها في تايب 1 ولا 2 ولا 3 في وجود اتر فيبريشن؟ مفيش دلوقتي في وجود اتر فيبريشن ولا في اي ولا ايه عشان اقول دي تايب 1 ولا 2 ولا 3. وانت قلت الحكايه دي مهمه، لان لو تايب 3 ما تحاولش تريفيرت الريزم، لو تايب 1 او 2 ممكن تحول للريزم كنترول. فازاي
Very,
اشخص الدايستوليك ديسفانكشن في وجود اتر فيبريشن؟
very good question, Dr. Hassan. As I said, first of all, in acute care setting and in ICU, we might not have the facility and the luxury of time to go with the sophisticated measurements. But what you have to do is to put in mind that the LV dysfunction is there in every patient with EF, especially if they're chronic, especially if they have associated mitral stenosis or pathology. This is number one. Number two, if you want to assess in ICU, the tissue Doppler can help with the E to E prime. But of course, you have, when you measure the E wave, you have to measure it over at least 10 beats. You have the average of 10. And you do the same with the E prime. So E to E prime is very valuable. If you know the history from before that your patient is already having a chronic EF, and this chronic EF is associated with, there is echo before, and this was LVDD as a grade 3, so you know that this patient is already grade 3. The question is very valid when you have those with paroxysmal EF, or you have those with, you don't know if they have EF, they are new onset EF, and again, the tissue Doppler will help on this. And of course, if you have very rapid EF, having the grading of LV diastolic dysfunction and any measurement would be very difficult.
طب ليا سؤالين تاني. السؤال التاني، انت قلت الانترفنتيكا سيبتم ديسكاينيزيا بتهلب في الدياجنوزس، ان ده يعني حالة ممكن تكون بالمون امبوليزم. بس قلت الديسكاينيزيا يعني السيبتم تو موف تو ذا ليفت فنتريكل، ومش ديسكاينيزيا during systole يموف للعكس.
Okay. When the pressure, there are two overloads on the RV, Dr. Hassan. There is volume overload when the dyskinesia, because the volume on the right ventricle will be bigger than the volume on the left ventricle in diastole. So presence of volume will make the pressure in diastole higher than the pressure in diastole, the RV more than the LV in diastole. So
Mm.
the septum will be pushed toward the left ventricle during the diastole in volume overload, probably
Industry.
acute
Okay.
cor-pulmonale. In
Mm.
acute cor-pulmonale, when the systolic pulmonary artery pressure goes above the pressure or equal to the pressure in the left ventricle, especially at the end of systole, when the left ventricle will start the diastole before milliseconds before the right ventricle, then the septum, because the pressure in the end systole in the right ventricle will be higher than the pressure at the very early diastole of the left ventricle. Because of this pressure difference, the septum will be shifted from the right side to the left, reversing the normal. Some people, they call it reverse Bernheim. Because Bernheim, as you said, the Bernheim phenomena is because of the pressure inside the left ventricle is higher than the pressure. Of course, maybe double the pressure in the RV, triple the pressure in the RV. The septum with the systole will be pushed toward the right side. But again, as I mentioned, with acute cor pulmonale or even with chronic cor pulmonale, the dyskinesia will be because of the pressure, high pressure on the RV compared to the pressure in the LV, which is less. This is induces the dyskinesia.
السؤال الثالث بقى، انت في الناس اللي عندهم اف وعندهم ليفت ventricular dysfunction ejection fraction مثلا 35 اقل، ما عندناش تشويس الا لينوكسين واميدارون وكل حاجه نيجاتيف نيجاتيف، بس انا بعمل حاجه مختلفه وبهاجم عليها بشده. ان في حالات الهارت فيلير طالما العام مش شوكت وهارت فيلير ورابيد اف هو الكونتريبيوتنج تو ذا ليفت ventricular failure، بحط مودريت دوز اوف فراباميل. الفرابامين لما بيسول هارت ريت من 120 ل 70 و80 بينليفاي النيجاتيف انتروبيك البسيط بتاعته، والحكايه دي بتنجح. وفوجئت واحد من تلامذتي كان دايما يهاجمني في المرور يقول لي ازاي يا دكتور حسن وده ممنوع ومش ممنوع. لما راح فرنسا يعمل دكتوراه فوجئ الدكتور اليوت رئيس القسم هناك بيعمل زيي، بيدي فراباميل في حالات الهارت فيلير اللي معاهم رابid اف. فايه رايك؟
والله يعني I would say, because we have some of our colleagues that we may confuse them, how I would say avoid negative inotropics while you are giving or recommending to give negative inotropics. The individualized care, Dr. Hassan, is very well appreciated. But the cornerstone of management, when you have EF, uncontrolled EF, with LV diastolic dysfunction, ejection fraction less than 35%, avoid all negative inotropicity and treat the heart failure. Treat the heart failure with all anti-failure medications and give time to anti-failure to work, and then introduce the beta blocker. I would totally appreciate that your notion of the vicious circle that the patient will be in. And this is again the notion that some of the people who still give small dose of beta blocker in heart failure patients when they have uncontrolled EF, that when you reduce the heart rate, you reduce the consumption of the myocardium and you reduce the need for oxygen and the blood supply, and this will improve the function. This is well accepted notion or idea. But
صح.
again, I'm afraid if we open it and then we give to the failing heart more negative inotropic drugs, that this will result in more failure. What very struck to me that when I saw colleagues, they are giving the beta blocker empirically, randomly, blindly, and they shot in dark. we should not shoot in dark. If you have wet lung due to LV severe systolic dysfunction, then the treatment is to alleviate the anxiety because of heart failure, because of congestion, because of hypoxia, because of lactic acidosis, because of this and that, and then the heart rate will be controlled. But if you
تمام.
go and try to interrupt the vicious circle with more negative inotropics, you fill the heart more, and then you require more rate controller with negative inotropic. It's a vicious circle. But
تمام.
you're
يمكن
very
انا
expert.
بتكلم على عيانين بيبقى الايجكشن على الورق 35، لكن هم كومبنسيتد هارت فيلير، والاف عامل لهم ازعاج بسبب انه 100 او 105،
Yeah, that's what I'm
فبيستخدموا
saying.
السمول.
Individualized care.
يس
There's
يس
no
يس
one size fits all.
يس، هو ده
Yeah,
المطلوب، ان
yeah,
الجايد لاين مش قرآن عشان اطبقها
yes, yes,
بحذافيرها، في تغييرات على بعض الحالات. صح.
definitely,
تمام.
definitely.
مين يحب يسأل دكتور أشرف قبل ما نختم المحاضرة؟